Okay, so by now you're probably wondering, is he ever going to talk about specific medications? Yes, here we are. So let's talk about the first generation of dopamine blocking medications, also called antipsychotics. So we can think about grouping these medications by their potency. So this is how many milligrams does it take to get the job done? And we can think of these as low potency or less potent medications all the way up to high potency medications. So the medications that I have put in bold here are the medications I'm going to talk about because they are sort of prototypical of each of these drug groups. So our less potent medications would be things like chlorpromazine, also known as thorazine, medium potency. So with that, you're talking about doses usually in the hundreds, average dose being around 300 milligrams. Your medium potency medications, you're going to use a tenth of that. So looking at about 30 milligrams of profenazine, for example, would be equivalent dose of 300 milligrams of chlorpromazine, all the way up to our high potency first generation antipsychotics, such as haloperidol, where your dose is going to be in single digits probably. Talk more about that in a moment. So chlorpromazine, so there is that that grid that we talked about earlier. So let's go through the different receptors and understand why this medication might have effect and why it may have side effects. So this is a low potency medication. So on your low end, maybe 100, 200 milligrams. Okay. Your high end, maybe as high as 800 milligrams. So a low potency medication. It blocks, as you can see, all 4 dopamine receptor families or groups. And there's a 5th dopamine that's not on here, but we're not going to worry about that today. Sort of pretty robust blockade on the D2 receptor, which is the key one for reducing those antipsychotic symptoms, or those psychotic symptoms rather, especially in the mesolimbic tract. However, it has significant antihistamine effects. So it blocks that H1 receptor in the brain. And that leads to things such as sedation. Most people know that thorazine is pretty sedating, right? Even if they've never given it, kind of has a reputation for being one of those medications that just would knock you out. And some of that is coming from the antihistamine effects. This can also lead to weight gain with chlorpromazine. You see also there, it blocks the M1 receptor, the muscarinic receptor, the acetylcholine receptors. Okay, so that gives it anticholinergic side effects, such as blurry vision, urinary retention, dry mouth. However, interestingly, those anticholinergic effects, coupled with the fact that it's a low potency drug, actually make movement issues such as EPS much less of a problem with this medication. So it's sort of got anticholinergic drug built into it, if you will. So this is much less likely to cause, say, an acute dystonia, or more likely the sort of Parkinsonian symptoms that you might see. This medication can be pretty sedating also because it blocks the noradrenergic alpha-1 receptor. And this is also what's going to affect blood pressure, which may lead to dizziness and orthostasis. Now, interestingly, just as a side note, this actually has a fair amount of serotonin 2A blockade, which is interesting because even though it's considered a first generation or typical antipsychotic, it inadvertently, and this is probably not by design, and it's just a side effect of the med, actually is more atypical than some other first generation antipsychotics, as we'll get to when we talk about haloperidol. Not on the test, just an interesting curiosity about pharmacology. So more about chlorpromazine. This was thorazine, of course, and it was advertised for just about everything back when it was in its heyday. Definitely can be used for nausea because it is a cousin of prochlorperazine. Can never say that word, compazine. It is available as an IM, so you could use it in an emergency. There's no long-acting injectable. It is metabolized through cytochrome P450 2D6, and it also inhibits that enzyme. And of course, any long-term dopamine blocking drug can lead to tardive dyskinesia. This is considered by the World Health Organization to be an essential medication because it's effective, generic, and cheap. And generally, lower doses of this medication are more preferential for the sedating side effects, the antihistaminic, the anti-adrenergic side effects, and the higher doses are considered to be more antipsychotic. Now let's move our attention to a medium potency first generation antipsychotic. In this case, we'll use a prototypical drug, profenazine, also known back in the day as Trilofan. So you can see this is a much smaller dose. So medium potency means that if we were using 300 milligrams of chlorpromazine, we're probably going to use like 3 milligrams of profenazine, but it can be dosed up to as high as 64 milligrams. So, but still a medium potency drug. It has this strong blockade, similar to chlorpromazine, on the D2 and also D3 receptors, which gives it that antipsychotic effect. Now, it's moderate on the antihistamine effects, so that makes it a little more weight neutral than chlorpromazine, which is generally a fairly weight positive drug. Makes sedation a little less with profenazine as well. And it also has moderate acetylcholine receptor blocking, so that M1 receptor. So this reduces the risk of EPS because it's like it's almost like it's got benzotropine or cogentin built into the pill, if you will, and that moderates some of those movement EPS side effects that we get when we block dopamine pathways in the nigrostriatal tract. And it has moderate norepinephrine receptor blocking. So you do get some sedation with this medication, but less than chlorpromazine. And you can get some of the orthostasis and dizziness and sedation that you get with the lower potency medications. So that's worth taking a look at too. All right, so profenazine, Trilofan, is, I kind of feel like it occupies that sort of sweet spot for me with first generation antipsychotics. It's not too sedating and it's also not too potent. So I like it for that reason. That's probably why they used it in the KD trial, because it was kind of that like, it's not haloperidol, it's not chlorpromazine, it's kind of, it's sort of the middle dose, right? And I like it because it generally doesn't cause those EPS symptoms because it has enough anticholinergic activity that you don't get the Parkinsonian symptoms, and you don't need to co-prescribe a medication like cogentin to go along with it, which is typically done with the higher potency antipsychotics like haloperidol. I sometimes would use it in conjunction with a first generation or second generation antipsychotic to increase the amount of dopamine 2 receptor blockade that I'm getting. So if I'm like, say at a pretty good dose of medication like olanzapine, the person's already taken 30, maybe 40 milligrams of that, and I'm like, I'd like to have a little more on top of that, I might prescribe, because I'm still getting some breakthrough psychotic symptoms, I might add something like 2 or 4 or 6 milligrams of profenazine. So it's a useful tool. Has a pretty wide dosing range, which gives it some flexibility, and it's cheap and generic because it's been around forever. All right, finally focusing on a high potency first generation antipsychotic, in this case, haloperidol. So you see, we're looking at doses generally in the single digit. Now, if you've been around for a long time, you may remember doses of haloperidol like 50 milligrams. Sometimes they would say dose to EPS. So people, they would have these really irresponsible, in my opinion, dosing scales where they would say, you keep giving this medication until the person either stops having psychotic symptoms or they lock up with EPS symptoms. They get a dystonia or they get really bad EPS. That typically happened with much higher doses. So if you were dosing somebody 20, 30, 40 milligrams, I had a patient who was on 40 milligrams of this stuff after a long psychiatric hospitalization. And the poor guy had such terrible EPS. The first thing I did was get him off of this stuff, get him to a much lower dose. But it has a very high potency. It blocks that D2 receptor quite strongly. So you can see here, it's got a pretty strong blockade across all the dopamine receptors except for D1. So what this does is it definitely is a very reliable antipsychotic, but it has a lot of side effects, primarily EPS, and also it's notorious for causing prolactinemia. Now you see it has really no activity on the H1 receptor, which means that it's pretty weight neutral and only moderately sedating. It does not have any activity on acetylcholine receptors, the muscarinic 1 receptors, which means that you're going to have a lot of EPS risk with this, which is often why this drug is co-prescribed with cogentin. They practically, they're just like peanut butter and jelly. They just go together. So you may see these two prescribed together if you're working particularly in inpatient or a psychiatric emergency type setting. And it does have some activity on that norepinephrine alpha-1 receptor, and that's is what can account for some of the sedation that you get. I don't want to say that haloperidol is not sedating at all, because it can be, and that probably is accounted for by that alpha-1 receptor activity. And this can also contribute to orthostasis and dizziness. And it has really no activity on the serotonin 2A receptor, which makes it very typical, kind of prototypical first generation antipsychotic, high potency. This is available as a long-acting injectable, something called haloperidol decanoate, and also a short-acting medication for emergency use. Occasionally it's used to control vocal tics that you can find in, say, Tourette's disorder. And it's been used in the past in small doses with people that have agitation related to dementia. That increasingly is being discouraged because of some of the increased risk that older people have for developing tardive dyskinesia quite easily with strong dopamine blocking medications. It's metabolized by cytochrome P450, 2D6, 1A2, and 3A4. And like I said, it's pretty intolerable if you give this medication without something to reverse the EPS, so an anticholinergic agent. And this is one of those medications that, if given chronically, will pretty reliably lead to tardive dyskinesia. However, its dependability and its low cost make it one of the essential medications as far as the WHO is concerned, because it does work. I can say that, having given this many times in emergency psychiatry settings where you've got somebody who may be very agitated and psychotic, say related to methamphetamine use. This stuff works. It's not something I'd want to take every day, and it's not something I would want to give a patient every day. So it's that balance. Useful tool, short-term, probably not a long-term med. All right, in our next talk, we'll talk about the second generation antipsychotics.